Hello, everyone. Welcome again to our last edition of Nurses Empowerment Seminar for the year of 2022. So today we'll be talking about something different, something very unfamiliar. People do not know about this area of nursing, and we're going to be bringing that very area to you guys, to everybody that is here today, and to those that will be listening to us in all our platforms. We're going to be bringing this to you, and it is free. It is at no cost to you. So we're not charging you anything to bring this information to you. We are actually bringing it to you free of charge. We are trying to improve the life of people, the life of nurses. That's why we called it Nurses Empowerment Seminar. Okay, so, and also we will be having a very special person in our midst. You know, like it's our tradition every time that we gather, I always try to give us a quote. And today's quote is one that I like so much. It says, when we strive to become better than we are, everything around us becomes better too. So when you strive to become better than you are presently, everything around you becomes better. So why I'm saying this is because of the person that we today. She's somebody who has made name for herself. She's somebody who has already gotten to somewhere. And then here we are, and we're going to listen to her. And the good thing about it is that all of us, if we pay keen attention to what she's going to say today, we will all become better ourselves too. So everything around her, including us, will become better by just this very particular seminar and her telling us more about this very topic that we're going to be discussing today. All right, so this is our flyer that we sent out. I believe everybody has seen it. This is our Nurses Empowerment Seminar flyer, and this is the last one for the year 2020. And we are talking about Clinical Documentation Improvement Practitioner, and an important part of nursing that a lot of people do not know about. So many people do not know about clinical documentation improvement practice. So a lot of people don't know about it, and that's how our own sister, she's one of our own, she's a Nigerian, she passed through every stage of becoming a nurse that you guys passed through in Nigeria. Now here she is in the United States making waves and doing exploits. So we'll be bringing all the Nigerians that has been doing exploits, making wave in the United States. We'll be bringing them to you next year. So we have started planning next year's program. And trust me, you don't want to miss next year's program. We'll have a lot in stock for you. And we have started making contact to a lot of people that will be speaking to you in our Nurses Empowerment project. So I want to make this like our monthly project that we're going to be bringing somebody special to you, and the person is going to come in and dissect a topic in nursing that people do not know about, just like an information session where you can get more information about nursing and how to even practice when you come in here. All right, so also I would like to read just a brief biography about a brief biography about the person that will be talking to us today. Her name is Olayemi Oduwole. She is a BSN nurse. She has a bachelor's in nursing. She has her registered nurse certificate. She's also an operating room nurse here in the United States. And also she went further to do clinical documentation improvement course. And also today she's working in the United States in this area. And she's going to tell us more about the area. She's a registered nurse with 11 years nursing experience in the operating room, acute care telemetry units, clinical research, and clinical documentation integrity. So she has worked in Nigeria, United Kingdom, and currently working in the United States. She's a certified medical surgical registered nurse. So she has taken that exam to become a certified medical surgical registered nurse. And she's a clinical documentation specialist. And also she's currently rounding up her master's degree in clinical research management. Oh my God. These are areas that, you know, when you talk about these areas, people do not actually know about what we're talking about today. So mind you, is an information that you have to hold on to. Okay, so I'm going to give her opportunity to share her screen. So I would just need her, I'll spotlight her first of all, and then I'll make her one of the hosts so that she can be able to share her screen. All right. So if you would turn on your video, Olayemi, so that we can. Yes. So yeah. Okay. So Olayemi is here with us, and then I want to pin her, and then try to make her a host.
Hi, everybody. I'm going to try to, do this before.
Okay, so I'm just going to make you host here so that you'll be able to share your screen. All right, try and see if you can share your screen now.
Yes, yes, I can. Let's see. Let's see. Okay, a minute. So,
Are you able to do that?
yes, but I'm just trying to minimize a little here. 1 minute, please.
Okay. So while she's getting ready, I just want to, ask a question, how everybody is doing. I believe everyone is doing okay. It's the end of the year, yay! And I believe that everybody is good, safe, sound. Just want to encourage you, whatever process that you're into right now to make your life better, don't give up on that. Just keep working on it. And before you know it, you're going to be there where exactly where you want or wish to be, okay? We were all in the same stage before. We were all somewhere looking and praying that things become better, and here we are today. And even when you get in here, let me tell you, the dream don't stop, okay? The dream don't stop. Even when you come to the United States, don't stop dreaming. Just keep on dreaming, and before you know it, you will get yourself at a pedestal that you never even dreamt of. That is how to improve. So keep on dreaming, keep on working on improving yourself, and then God will show up for you and do something to make you get to where you want to be. Okay, that's just my advice. I was just trying to, say that before our slides come up. Okay, all right, I'm going to hand over to Olayemi. Olayemi, please, these are my people. They are all nurses. They are people like you. They've been where you are, so I want you to use the lowest term possible. I know you've gone far in this profession, so please come down to our level.
I'm going to try as much as possible to tell you what I can. I've really not been in this field for too long, and also I can't tell you everything that you need to know today, but I'm going to try to give you as much information as I think that you need. Are you all able to see my screen?
Yes, we are.
Okay, all right. So today, you've already said a lot about me, so I don't think I have to say much. So I'm just going to go directly into the presentation. So I'll be talking to you about CDI. And basically, it's clinical documentation improvement. Some people call it clinical documentation and integrity. It's still the same thing. It's all about clinical documentation, how to ensure high quality documentation. So today we'll be talking about what CDI is, why CDI, why would anybody want to do CDI? Why are healthcare organizations, why are they employing CDS? Why is CDI going to continue to be relevant? Because you don't want to be in a field that maybe in the next 5 years, it's no longer relevant and everybody's trying to say, oh, I've been out of bedside for a while. Where do I go? What do I do? So we're going to talk about why it is relevant to both the healthcare organization and why any nurse who wants to be a CDS. We'll talk about the challenges, because I believe that there is nothing that is good that doesn't have its own challenges. We'll talk about the career pathway for nurses and for medical graduates too, foreign medical graduates. We'll also talk about prospect of CDI in the USA. I think there are about 4 people waiting to enter the group. Let me see if I could admit some of them. Yeah. Yeah, okay. So next, now these are the abbreviation I'll be using in the course of this presentation. I am showing this right now, so when I'm mentioning these names, we understand what we're talking about. CDI, like I said earlier, is clinical documentation, is clinical documentation improvement. CMS is Center for Medicare and Medicaid Services. CMS is just like NHIS in Nigeria. It's like a government insurance company that pays the hospital for patients that are covered under them. ACDIS is the Association of Clinical Documentation Integrity Specialists. AHIMA is American Health Information Management Association. These two associations, they kind of regulate what goes on in CDI and health information management. And the major differences between them, that I would mention that there are other differences, but for right now, I'll talk about the fact that ACDIS offer they offer the CCDS certification, and that is the Certified Clinical Documentation Specialist, which I will mention later during the course of this presentation. And AIMA offers the CDIP certification, which is the Clinical Documentation Improvement Practitioner. Now, the two certifications, I'll talk about them later. RHIT is Registered Health Information Technician. There are also professionals, health information professionals that could also be a CDS. CDS, I'm mentioning, is the Clinical Documentation Specialist. Nurse practitioner, we all know that NPs, PA, physician assistants, FMGs, that's what they use for any foreign medical graduates that are in the United States. Either from Nigeria, from India, from Pakistani, from anywhere else. They are all referred to as FMGs. So now, what is CDI? So CDI, like I mentioned, Clinical Documentation Improvement, bridges the gap between what CMS requires, that is the payer, what they require, and the language provider uses to represent the patient's medical condition. So this CMS, the payer now, they pay based on the severity of illness, based on the risk of mortality of that patient. And it is important that if a provider is treating a patient that is very sick, the documentation must clearly show that that patient is very sick. If not, they will not get the payment for the very sick patient. For instance, you are treating a patient that probably has, let's say, severe malnutrition now, and then your documentation says moderate malnutrition. There is a difference between the two and the way they pay for both of them. So for you to get your accurate documentation, for you to get the accurate payment, your documentation must depict the clinical picture of that patient. High quality documentation fully represents documentation that fully represents the acuity, severity, and risk of mortality of the patient, which ultimately results in improved quality of care, reduce claims or reimbursement in the health, and increase hospital revenue. So when we talk about CDI, it also still has something to do with ensuring, it has a lot to do with ensuring high quality of care for the patient in the hospital. Imagine a patient that probably is admitted for pneumonia, for instance, also meets the sepsis criteria. That kind of patient, if sepsis is not documented or if the right documentation is not in the note, the patient might not even get the care that patient should get. But if the documentation is complete, it will ensure that that patient gets the quality of care, the level of care that they should have while on admission. So who is a CDS? Who is a clinical documentation specialist? A clinical documentation specialist is a professional, is a registered nurse. It could be a registered nurse, nurse practitioner, physician assistant, foreign medical graduate, RHITs, who review medical records to ensure that it is complete and accurate. Nurses are great assets in CDI because of our clinical background and medical knowledge, which help us to identify inconsistencies and bring ambiguity in documentation. Now, what do I mean by ambiguous documentation. What do I mean by conflicting documentation? Now, if we talk about ambiguity, we talk about a word that does not give us specificity. For instance, a patient is admitted in the hospital, probably the provider documented heart failure. It says, oh, this patient has CHF and patient is being treated with maybe IV LASIK, there's edema, there's pulmonary effusion, and all you have in documentation is CHF. You know, it doesn't tell us the type, the chronicity, whether it is systolic or diastolic. It will just automatically, when the coders code this information, it will go to the lowest level of severity, and that is what will be sent for billing. So, but as CDS, as a clinical documentation specialist, it is now our responsibility to query the provider and let them, based on the clinical picture of that patient, to ensure that the clinical picture of that patient is captured. A patient with chronic heart failure, for instance, should not be getting an IV LASIK. For you to administer IV medication to that patient, means something acute is going on. You look at the, because all of this information, as the CDS, you have access to the patient's documentation, you're able to see what is going on with the patient. You can use those information to query to the provider. So that is what I mean by ambiguity. Now, when we talk about conflicting information, one scenario that comes to my head right now is probably a patient being admitted to the hospital, a COPD patient that just came in for probably shortness of breath, increased need of oxygen. And then a consult is sent to the pulmonologist, and then the pulmonologist came in, saw the patient, and said the patient has acute and chronic respiratory failure. And then afterwards, the attending or the hospitalist come in, they document chronic respiratory failure. Those are two different things, you know. At this point, you need to clarify with the provider, does this patient actually have acute and chronic respiratory failure, or is it chronic respiratory failure? Because the way both of them are seen, the way the acuity of care for both of them, they are very different. So at the same time, as much as we're trying to make sure that they capture the accurate clinical picture of the patient, we also want to make sure that they are not probably capturing what that patient does not have. An example is this: a patient has pneumonia again, and then they document sepsis. And then you look at the patient's information, and that patient does not even meet sepsis criteria. Now you need to send what they call a validation query. Like, you ask them, are you sure this patient actually have sepsis? Like, it's not our duty to say this patient does not have sepsis. No, we'll just like clarify. They have to say it because they are the provider, they are the one taking care of the patient. So you just basically just clarify with them, because if this information, the billing information, gets to the payer, they look at it, they are like, oh, this patient does not have sepsis. They're going to deny the claim. So as much as possible, you want to make sure that hospitals want to ensure that they get what is accurate, you don't get claims denial. That is that about it. Here we're talking about why CDI. Why are we going to continue to be relevant? Why will healthcare organization continue to have CDI or to employ CDS? So the first reason is quality of care. Everybody wants good quality of care. You know, the kind of quality of care the hospital gives to their patients don't affect their return. Like, patients, they do research hospital, they research their provider, they research the quality of care they give in hospital before they go there. And if it's an emergency and they don't like that hospital, they request a transfer. So hospital wants to make sure that they give the best quality of care, and they understand that high quality documentation is essential to high quality care. It also helps to reduce documentation errors, because, like I said, with through documentation, we show that everything you're capturing what you're supposed to capture, like everything is just what it's supposed to be. Better denials management, I already mentioned that earlier when I made sepsis, an example. Improves revenue capture. Like I said, if you are not accurate, if you use ambiguous term in the documentation, it's just going to code to the lowest possible severity. And when they are able to capture the actual severity of that patient, the actual clinical picture of that patient, most times the hospital, they see that they have higher severity level. Now here I talked about increased CMI, increased case mix index, which indicates severity of patients seen in an hospital. Now every hospital have like a CMI. It's just like a number that tells them how that kind of represents the severity of the patient that this kind of hospital that they see. Now, the easiest way for me to explain this to you in the lamest time possible is using the level of care in Nigeria as an example. You know, in Nigeria, we do have, we have the primary level, the secondary level, the tertiary level. We have the healthcare centers that are under the primary. We have the general hospitals that are under the secondary, and we have the teaching hospitals that are under the tertiary level of care. So you know that if you take a patient to a place like UCH, for instance, or patients being treated there are very, very sick patients, and they are paid accordingly. And those in the middle class, maybe patients that are just having some infectious diseases, and then the primary care patients are patients that you can see on our patient visit. So that's how we understand hospital in Nigeria. But here, most of the hospitals are privatized. They don't bear the word teaching hospital. They are just their names, you know. And the way to know the level of care that they give is by knowing what their CMI is. Where I used to work in a small town in Virginia. The hospital, whenever we have in the hospital, there are some people waiting. I just want to quickly, just want to add with them. Yeah. Okay. So yeah. So like I was saying, when we work in where I was working before, yeah. So when we have a patient that comes in with chest pain, we do stress test, and if it is positive, because the hospital does not have the resources to take care of a patient with MI, for instance, they will have to transfer that patient to a place where they can get cardiac catheterization done. Now, that kind of hospital, the CMI will be lower to the kind of hospital that they're transferring patients to, right? So from the name, sometimes we don't know, but from the CMI, you're able to classify hospitals based on the severity level of the patient that you take care of, and also affect the kind of payment that they receive. Yeah, this is very important, financial benefit. They don't talk about it very much. We like to talk about the fact that it is about patient quality, but really it does help. It has great financial benefit for the hospital. According to the medical coding news in 2018, a 2016 report found that hospital with more than 150 beds saw a profit of at least $1.5 million in revenue and claims reimbursement. Who doesn't like money? So yeah, now when we're talking about nurses, why do you want to leave bedside to be working in CDI? Why are people leaving bedside? Why are they staying in CDI for a while? So when I first heard about CDI, I was like, am I sure I'm going to like this field? Like, I wanted to research more about it. I went on Facebook, but on all social media possible things. Like, if I do this thing, will I really enjoy it? So as I was researching it, I found a Facebook page for CDI. Now, someone like me too, trying to find information, asked a question on that page and said that, and asked if nurses who had a career change to CDI, asking if they were liking it. So this right here, some of the information, some of the responses that they got that people give. So each one of this information here, I gave my different notes. I couldn't capture everything. They were more than that. I just felt I should just share this with you. Somebody said, absolutely love it. 7.5 years and still loving the CDI field. Another person said, going on 9 years in CDI, this is my retirement job. I love it. Everything CDI has been amazing for me. I absolutely love CDI and cannot imagine walking away from it. 10 years in CDI, can't see myself in another specialty. It is an amazing field. It's a lot to learn, but best thing I've ever done. Best thing ever for my career. Like, I went through that page, and honestly, I couldn't find one single negative about the career. So yeah, I'm sure. And I can also tell you that it's been good. Like, the little time I've been there, I've really liked it. And I thought that, yeah, to watch with you guys. So why CDI? Why CDI still for us, apart from what people see, like the fact that they enjoy it, they love it. Why do these people love it? What are they saying about it? You know, they are we all know that nursing profession is majorly about bedside, like people work to give their patient care to the patients in the hospital. We have a lot of setting, and most of our nursing jobs are on the floor. A lot of it are even, you know, you're on your feet, attending to patients, talking to relatives. Some of us, when we get to a point, you're like, oh my God, I'm done. I want to leave bedside. You know, if you are thinking about leaving bedside, this is one good way to leave bedside. So CDI, right now, currently, before the pandemic, a lot of CDI positions were working in office, they were in office position. But the pandemic caused a lot of organizations to realize that a lot of jobs can actually be done from home, and they realize that there are even better productivity with these specialists from home. Like these people are even having, they're even doing more working from home. Like they are seeing higher productivity. So now CDI is now a field where a lot of all the jobs are remote opportunities. Like if you go online, you will see a lot. Like almost every day, I get job offers on my phone. Remote job. I keep telling them no. Like there are lots and lots of remote jobs. You can leave one and get into another one. Especially when you have the experience, it is that easy. But there are still some hybrid jobs out there where they do 3 or 4 days at home and 1 day in office. And there are still some jobs out there that is strictly in office. And I know that some places what they do is they have a new CDI and the person does not have experience, they'll tell them, oh, come work in office for 6 months when you have your experience and then work from home. While some people still do their training virtually, because really you can learn what you need to learn. But CDI virtually as well. So because of this, CDI has the benefit of every other remote job out there. In a lot of tech right now, like people in IT do work remote jobs now. So all the benefit that working from home has, and that is better work-life balance. You know, it's most hospitals, it's like an 8 to 4 job or a 9 to 5 job, or it's even more flexible than that, depending on the hospital. Now you get to work from home, no commute time, wake up like can practically wake up and just sit down in front of computer and start working. Yeah, flexible schedules depending on the hospital. You know, it varies. The flexibility varies, but I can tell you it is still very flexible. Some people will say, okay, we just want to work 5 hours out of your time while doing the normal working hours. You know, some people would, I've seen cases where people wake up 2 a.m. and do their work. Some cases where they still like work in the evening time if they can't work in the day. But it all depends, like I said, you can't do that with all organizations. Some places they want you to do your time, you know, but still, it's still pretty flexible. And lower cost of living, yeah, you know, the thing with job these days is that, okay, there's this high paying job you get probably in New York City or probably in California, but the cost of living in that area will take away all of your money. But we see there, you could actually get a job in California, we get paid good money and probably live in a place like in a low cost environment where rent is like really cheap. And also, with the cost of living, you save on cars. You know, you don't have to you have to buy scrubs, winter clothing that you be wanting to work. And I do have people that they are not even paying for childcare because they're able to work and keep an eye on their babies without having to get them to daycare, which we all know is very expensive here in the United States.
Mm-hmm.
Yeah. So what are the challenges of CDI? So basically, CDI involves working with computer software. So we need to have good computer skills. So modern computer skills is need to be successful. So if we are not very good with computer, it might be a challenge. Or if you are able to come into this country and we have already in the United States, and we have worked with the EMR, that is the same as EPIC, then we will be able to cope effectively with CDI. Basically, they use some softwares which you get used to, and before you know it, you'll be able to work in the field. Most organizations, they want some form of experience. Initially, if they're trying to get in the field, they're like, we want experience, we want experience. But there are also ways to go about this, to make sure that you get what they want. And, there's even no job. Even when I remember when I first went in nursing school, I'll get to a place, I'll show them all my posting. They'll be like, these are just posting, you don't have experience. But the moment you have an hospital that is willing to give you a chance, then then it's going to be worth it on the long run. So there may be a pay cut when transitioning, especially if there is no experience at all in CDI. But one can make up for the pay cut from a year or two or even less, which some people may get, and some people may get a pay raise from their first job. Like the fact that some people get a pay cut does not mean another person will get a pay cut. It all depends on how we are able to sell ourselves to the employer. Here in the United States, it's all about your mouth and how you can sell yourself to your employer. So for many people that have taken pay cuts, still they commented, because I researched all of this, and they commented that it was worth it for them because they don't know how to go through the stress of being a bedside nurse. They work remotely and doesn't have to spend money on gas, scrub, workout feed, they make up, they don't have to spend money on makeup, cafeteria meals, which we know are more expensive than homemade meals. They can work in their pajamas and eat their homemade meals. They also have more time for their family. I know some people, like I mentioned earlier, I know some people that work from home and still take care of their children, like young children that cannot go to school yet. So with the pay cuts, with a couple of years experience, education, and probably a change of job, there's definitely the pay rise will definitely come. So I just want to add here that remote position does not equal laziness. Like, because it is remote, we can't say that, oh yeah, I'm just going to walk away and go and do my thing for 2 hours. There are ways this organization, they track productivity. They know, they are able to see when they are logged in, we are logged out. They want to track all of these things. So if we do get the job in the future, let's just be disciplined about it, do what we have to do. You can still do your thing, but you have to be smart about it. So what is the prospect of CDI in the United States? Like I mentioned earlier, I already told you about the benefits of the healthcare organizations. And because of that, why CDI is going to continue to be relevant. I was trying to get the recent information about that, but I just couldn't find it. But I know there's something, I've seen something more recent. But the one I could find was by May 2014, and it suggested that CDIs will continue to expand as 80% of hospitals utilized in their study as implemented CDI, and also stated that more jobs will come from hospitals with greater than 350 beds. Their results also show that CDS will be in demand from smaller hospitals. And I can tell you that was in 2014, this is 2022 now. A lot of hospitals with smaller beds than 350 have CDI. And I know that more hospitals will continue to have CDI because the benefit is just, for the hospital, it's just too much. It's just too much. Every organization wants to make money, and trust me, and if they understand what this is they're going to do, a lot of them will start having CDI. Yeah. So now let's talk about competition. I know a lot of people want to hear about this. So as of November 25, 2022, the average salary in the United States is $99,670, which is way more than the average earning in the United States. And they said that they have seen, that is, recruiters said that they have seen people earning as high as $166,000 a year. Now, this same site I went there about a week ago, and the average salary was just $89,000. And in just 7 days, there is a $10,000 increase. I think that's an indication of the relevance of CDS and healthcare. Like, it continues to go, it continues to increase. And, because it is, it continues to increase. I can tell you that I do know people that even that earning, on average, it does look right on average. And this also looks right, because I don't know people that even earning way more than this. As well, I remember, because it is a remote position, and if depending on how flexible your job is and what time it is, you are done, not feeling stressed, you could take on an additional side, give on the side, repeat. I also see there it could be a contract job that will not that you could be doing PRN, because basically just working on your computer. So yeah, it's possible to get as high as this money and even more than. And remember, with the first job, there's a chance that you might get a pay cut, you might get up to this amount, and with experience, you can get up to that and more. So, salary is based on years of experience, years of nursing experience is inclusive. They're not just going to say, "Oh yeah, you're just coming to CDI, so I'm just going to be like a new grad." No, they're going to look at when you graduated from college, and they're going to start counting and calculating the salary based on that. But with more CDI experience comes more money. So there are numerous contract job opportunities. We all know contract job pays very well in the United States. They don't have as many benefits as full-time jobs, but they do pay more than full-time jobs.
Mm-hmm.
So what are the career pathways for nurses and foreign medical graduates? Yeah, even though for you to get a CDIP certification, you just need another degree or higher in relevant fields. A lot of jobs I see out there, they say that they would prefer BSN or bachelor's and MBBS certificate, that is medical doctors from Nigeria or from any other country. For you to take CDIP certification, you basically just need to go on our email website and register, tell them that you're a registered nurse or something, and then you'll be able to get the CDIP exam. And you'll be able to take the exam. Now, taking the exam, having the CDIP certification, remember I said that you want experience. So having the CDIP certification helps to increase the chances of getting a job. Now, CCDS is the certification that is taken, that is offered by CDIS. And you need to have worked in CDI for 2 years to be able to take this certification exam. And I think with the certification, when you see it shows that you really know what you're doing. And like I said, probably also increase your marketability. I don't have this yet, and I hope to get it someday. ACDIS, one way to get into it, like I mentioned, experience, knowing about what CDS is. Could take this apprenticeship course, by going on this website. I kept this link in here for people that might be interested. And the course right now is about $295. Like, everybody tells you what CDI is all about. Like, I think at the end of the day, there's an exam that you're going to take. Yeah, that's one way to get that preliminary experience. Now, this is CDI Academy. I just came across them. I didn't really know about them when I was trying to get into CDI. When I read what they have so far, I think it's really good. And I think I saw that they were charging about $750. But the good thing about them is that they said that the rules stay with you till you get a job. Like, if you get a job, and I think they also employ CDS, like for hospitals, like a contract job kind of. They have a big deal like that too, that they kind of employ CDS as well. Another way to get in is by volunteering and shadowing. For instance, you are working in an hospital in the United States, you could actually, if that hospital has CDI department, you could volunteer there, you could shadow them, see what they are doing. Maybe when they are ready to make when they're employing, it will be easy for you to transfer to that unit because you have made all of these steps, and of course, you have been volunteering and shadowing there as well. And then even if the hospital is when employing, the fact that you've been volunteering, that then you know something about it, you can put that in your resume as well, and that will serve as a form of experience and help you to get into CDI. So these are my references. So do you have any questions for me?
Whoa, thank you so much, Yemi. Thank you very much.
You're welcome.
That is awesome. That is awesome. And We are going to be asking questions, but me too, I have some questions, because, side hustle is something that everybody needs in this country. So first of all, you said something about this being a kind of something that you can do remotely. So can you do it and still maintain maybe your other jobs? Is it possible?
Well, if your other job is going to be probably a weekend job, maybe you do, for some people that do night shift, if they do maybe weekend night shift, it's basically Monday to Friday, 8 to 4, probably you do 6 a.m. to 2:30, or depending on the flexibility of the place. So if it's going to be bedside, then, or probably clinical area where you have to go in, it's best for it to be a weekend thing. And even some people, they get to CDI jobs, They are doing one here and doing the other one. You just look at how it works best for you.
Okay. So, guys, from what I understand that this CDI do is they try to cross-check every document that a doctor submits after treating a patient. They go over it one page after another to make sure that that payment that doctor is applying to be paid is will I say is supposed or is what the doctor supposed to be paid. I don't know if there's any other word for me to use for that, but they try to check the integrity. If you said that a patient had maybe say malaria, let me just use that. Did the patient get the treatment for malaria? Was that payment that you're requesting supposed to, is it something that is supposed to go to you? And so in some cases I've seen, because I know a little about this, I've seen cases where payments are being declined or denied because they believe that the doctor may have caused the issue. A patient is not supposed to pay for coming to the hospital whole and not having bed sore and leaving the hospital with bed sore, or coming to the hospital and the investigation says no infection, the first investigation, and before or midway into treatment, the patient has all manner of infections. You understand? Which means that may have been gotten to the hospital. So this payment might be something that would need to be discussed, or something that will not go to the facility, if I may say. Yemi, you know this more than me. Am I on the right track? You can correct me if I'm going.
Well, you tried. Like, yeah. Well, the thing is that there's what we call concurrent review and retrospective review. Basically, most times CBS, they do what we call concurrent review, which is when that patient is still in the hospital. Then the retrospective is done by the coders after the patient has been discharged. Okay. For instance, the patient was admitted, the way, just like we are registered nurses on the floor and we can open the chart and document, the CDS can see it as you are, the moment you save it, they are seeing the documentation. Yeah. So the moment, while the patient is still there in the hospital, that is why it can still ensure high quality care. Because you are seeing something, patient is still there, you can query them. They would look at it and probably, it will still affect the patient care because the patient is still in the hospital getting that treatment.
Good. Now, do you notice, sorry to cut you short, do you notice any, maybe any abnormalities with the method of treatment and then inform the doctor and that becomes changed or something? Or if the PA is saying something different and the doctor is saying something different, how do you communicate that?
Okay, for instance, we have what we call queries. We send queries to providers. And basically, you don't want to send what they call a leading query. You want to just give them clinical indicators, risk factors, treatments to point them in the right direction. Now, because you understand what the clinical aspect of care of the patient, because they are medical providers too, they understand these criteria as well. And part of CDI is also physician education. That's another aspect. Like I told you earlier, I can't tell you everything today. But part of it is physician education. So over time, we have people within the CDI that also educate the provider. They're like, okay, when you see queries like this is what we're looking for, that is this. They tell them benefits, they get them on board. So they too, they understand when you ask them some of these questions. So if you see like documentation, for instance, you send them a query, you show them the patient's clinical indicators. Maybe let me give you an instance, like, okay, sepsis, for instance, has a criteria. And the criteria could be a low blood pressure, maybe systolic blood pressure of less than 90 millimeter of mercury, heart rate over 90, temperature above 38 3 degrees Celsius, and probably an infection source, probably pneumonia, UTI. And then you're seeing all of these things, and you cannot see the diagnosis of sepsis. At that point, because sepsis has not been diagnosed, you don't want to tell them, does this patient have sepsis? You are leading them. You want to give them those criteria and ask them if they have any additional diagnosis that this patient might have in that setting. Based on those clinical indicators that you have shown them, So most times when you send them something like that, they know what you're asking for. They will give you what you want. Or you say, oh, fine, this patient came in with CHF according to maybe the BNP says it is this, Seeing that number alone for them, they know what they are giving IV, let's say this is documented. Do you have it, can you clarify? So they would give you what you want. And the moment they respond to that query, it's part of patient documentation. And it can be captured and it can be used. If somebody documents A somewhere and somebody else documenting somebody else, you ask. And most times the attending documentation kind of takes priority over that of the consultant. So most times you send your query to, if you send a query to the attending, for example, and it says, okay, it is A, not B, then that A, it is actually that A. That is what it is the A. So there are already rules, there are guidance about all of these things that helps us and them to know how to deal with different situations.
Yeah. So you did a great job to that. But I'm having a follow-up question to that. So would you say that as a CDI you work for the hospital or you work for the insurance company? So
it could be both ways. Like I said, it is the beginning. Like CDS work for the hospital. Also, we have DRG auditors as well. They could also work for insurance company to make sure that they are actually, so it could, like I said, you could work for but mostly for right now, at this point, majorly at the beginning, when you're getting to understanding it, you start working with the hospital. Over the years, can be like, oh yeah, I know so much about it now. I know so much about DRGs, I know so much about all. You can work with an insurance company. And then you'll not be the one looking at their documentation and be like, that is not right.
So now, when you say work for the hospital, so you help to improve care by pointing doctors to the right direction. Is that correct?
Yeah.
And at the same time, you save money for the hospital by making sure that the right thing is documented and the hospitals get paid what they are supposed to be paid. Is that correct?
Yes, accurate reimbursement here.
Yeah. So these are the two ways it goes. So you help the hospital and you also help the patients to improve the care.
You also help the doctors too.
Yeah, I help the doctors to do their job.
Because there's what they call the physician report card. All of them, when they take, because of the kind of care that they give to the patient, now they can actually capture what they are supposed to capture. They can say, oh, I achieved this level of severity. Like, I don't have this. Okay, let me give you an example. Now, there are some conditions that they call patient safety indicators, like pressure sore that you mentioned earlier, probably patient is developing respiratory failure while on admission, developing sepsis while on admission. Those are quality areas. Those are things that you don't want patient developing quality while in the hospital. The hospital get docked for it. So if, for instance, a patient comes into the hospital today, and 3 days later, they documented character-associated urinary tract infection. And that kind of, if that is what it is, it actually affects the quality rating of the hospital, because it means the patient got characterized and got infection in the hospital, which is very bad. It is so bad that they kind of, like, I don't think the hospital is going to get paid for that admission, because they're going to kind of fine them also. But as if the CDS look through the documentation and is able to identify that this patient came in with that COTI, or came in with that sepsis, or came in with that respiratory failure, then the hospital don't get docked for it. Then it is not a quality issue for the hospital. One way to explain that is sometimes all of these conditions are not diagnosed on admission, but later it comes into the note. The fact that it is not removed on the admission it means it is not present on admission, but it could be present on admission if there are indications and signs that these things were there on admission. For instance, I looked through the note and realized this patient came in with a catheter. Even though it wasn't documented on the day one that this patient had 40 or associated urinary tract infection or sepsis or whatever it is on admission. And you could trace it back that, okay, when this patient came in, the patient had fever, this patient had pneumonia, the heart rate was high, lactate level was high. At that point, you now ask the question, giving the doctor this indication that is this thing present on admission? If the doctor says that it is present on admission, based on those criteria, then it is pretended to get looked for. Does that make sense?
Yeah, that makes a lot of sense. That makes a lot of sense.
So it also helps. So it helps the provider, it helps the hospital, it helps the patient, kind of helps everybody.
Everywhere. Wow. So I know you've had like real life scenarios where people who come from Nigeria and other foreign trained medical graduates and all that. Do you think they fit in so well into the position and they are able to write their USMLE or continue on that same job? So how does that?
Definitely.
So
yes, definitely.
In terms of adaptation, is this something that somebody will get into within a few months or a few years? How long does it take for someone to complete the training?
Well, it depends on the person. Like, it's individual different. Like, you could decide that I'm going to take, like, the best thing to do is just to take the certification examination, and then probably do all these courses that I mentioned. If they can, I didn't do them, but if they can, they should. If they don't have access to a place where they could volunteer or shadow or have access to a coach, then I would suggest that they do that. If they do that, it's going to make it really, really, really fast for them to get a job because they can understand what they're going to be doing when they get the job. They can, talk about what that field is about, what CDI is doing their interview. But the thing is that for registered nurses, for foreign medical graduates, they don't have to do anything. We'll just take the certification examination. That is the CDIP that I mentioned. So they will just register in 3 days. 3 days of registering, we get your authorization to test. So now it depends on you getting your materials, how long it's going to take for you to read. I can tell you I read something in 3 weeks, somebody will need 6 weeks to read it. So it's all about, so it's not going to take years. It's all about the person that is preparing for it, how determined they are, how motivated they are to do it. It's all about the individual.
So I have some people right now who are in Nigeria, their husband are, trying to relocate. Can they start this registration process from Nigeria? Can they even work as a CDI from Nigeria since it's a remote job?
Well, I don't know how that works from Nigeria, honestly. Right? I've heard of situations.
I mean, Nigeria, other countries,
Yeah, I've heard of situations. Yeah, it is possible actually.
Because I know Indians do a lot of things right now.
Exactly. That is what
India. You understand?
That was what I was going to talk about. In my how do I describe it now? There's in my hospital, in my current hospital, I think they have CDI. The CDI department, they contracted it out to an agency, and there are some Indians working from India. It's from India. Yes. So it is possible. Yes, it is possible. But because we don't have CDI in Nigeria, you need some experience. So for those Indians, they probably have it in their country, and that is why they could do it. But the only thing I can say is that I understand a lot of nurses on this platform are either here or are planning to migrate into this country. What they could do is get some of the materials that they need to practice to take the certification exam. They can start reading, so that the moment they get in, they write their exams, and after when they're doing their exams, they can start practicing. I think that what I know, but the pathway of working from another country, I don't know it. I can't talk about it.
I was just brainstorming because I know some people want to get going.
But definitely, it is possible because I do know that IT people, there are some people that work for Nigeria and they are in IT. So and I also know people. I've heard of people that they are working in the United States as CDI, and they went to Nigeria on vacation, and they were still working while they were on vacation. Can you imagine that?
Right. So Somebody is actually saying, you said there is no CDI in Nigeria. I don't know, but somebody is saying, is CDI not like something like Savicom in Nigeria? So,
well, I don't know, but all I know, I can't answer that question because I really don't know what Savicom. I've heard of Savicom, but I really don't know to what extent they do all of these things.
I think
So, yeah,
Savicom is
but
about quality of service, but when I worked in a tertiary institution, the only thing I know Savicom for is they try to catch people who come late.
yeah,
It's like
but you know,
Chronos.
CDI involves some coding skills as well. It
Hello.
involves knowing all these things. Hi.
Okay, somebody wants to say something. Good. Go ahead.
Okay. I thank our presenter for the wonderful presentation. We have something similar in Nigeria, but not properly handled. Because I'm working currently in National Health Insurance Clinic.
Yeah, NHIS is just like
the
the CMS I talked about.
Yes. So the health management organization, they have their desk officers that we look into whatever is written for patients.
Yes.
And criticize what is written, whether investigation, drug, whether it is relevant to the diagnosis of the patient. Yes. But nowadays it's observed that those people are not professionals. Maybe they are just an administrators. At times, a patient that complains of chest pain, that the doctor don't even know how to go about the diagnosis and ordered ECG for the patient. They will query the investigation.
Yeah. They will query ECG for chest pain.
Yes, which means
they want them to
know
make their diagnosis. Yeah, exactly.
So at times we have to call them personally. That do you know what you are doing?
I think they are using the wrong personnel for that. Yeah, it should be nurses.
Some of them recruit nurses, but you know there is acute shortage of nurses in Nigeria now.
Right.
So they just recruit anybody that they seems can speak English and attend to customer.
It's not customer service.
Even if you request a patient that is a non-hypertensive patient that need code for antihypertensive drugs, they will ask for the current blood pressure of the patient, that it should be sent with the request. We now send them back. What if the blood pressure is under control and is within normal range? You give out the code. So there are so many things that are not being done normally in Nigeria concerning this. So they are trying to minimize the money being collected by the hospital from the health management organizations. Why doing it at the detriment of the patients?
Yeah.
Yay.
Yeah, I get your point. Yeah. Wow. Well, thank you, Good. You know, the way that I understand Yemi is talking about it is, you're talking about it from the National Health Insurance Scheme perspective. But now, this is supposed to be something that every hospital should have, so that as long as somebody is admitted to the hospital and there is an open medical record for that person, somebody is supposed to be reviewing the ongoing medical treatment that the doctor is giving. It's not even like in retrospect that the treatment has already been done and then you are going through the file to know, but this is an ongoing thing, but I know National Health Insurance Scheme, people go there, collect medications and everything, and then they need to employ people who can actually, have knowledge of pathophysiology and be able to help in the process of pointing doctors to the right direction in that regard. Okay, but I don't know if anybody has any more questions. This is an interesting topic. If you leave me, I'll keep on interacting with Yemi because I have so much even to ask her right now. But let me give us more opportunity. Do you have any question for Yemi that we can ask her today? Okay, so we have Vivian. Vivian, we can take your question right now.
Okay, can you hear me?
Yes.
Yes, I can.
Okay, I'm sorry, maybe I came late to the program. I didn't get a place whereby maybe those that their husbands are doctors can be able to, from this program, can be able to maybe go back to their roots. Is it that you work with these people? Like, how does it help you to go to maybe go back and write the exam that medical doctors write here?
Okay.
Well, the thing is that I think it's going to be an advantage for them when they're applying for their residency, because they are still in the clinical setting. They are reviewing documentation. It's all about medical diagnosis. They are still close to they still have this provider relationship. They still see medical patients. So basically, it's just something they can do while they are writing their USMLE and applying for residency. Like, it's a job they can do. You know, some people come into this country and they don't even know what they're going to do. Like, my husband is a doctor. I remember when he first came in, it was challenging identifying the things that he could do. It was challenging, and a lot of people can testify to it.
That is
But
true.
the moment we discovered it, oh my God, we're like, what? Where on the how come we didn't know about this? Like, we would have given anything to know about this in the moment we came into this country.
Wow.
Honestly, yeah. So it is something that just by the fact that they are medical doctors from Nigeria and they have medical background, they can take the CDIP examination, they can then apply for jobs. And I tell you, they are, like, for instance, I have a medical doctor that I'm working with. She's from Nigeria. She's working at the CDS, and also a physician assistant is working in my hospital as well. So it's not just even nurse practitioners that are getting CDI jobs.
Okay.
That's how I would say.
Okay. That's great. And do you have another question, Vivian?
No, I'm okay. Thank you very much.
Thank you. So if you have a husband that is a doctor, or any husband that is, has a bachelor's degree that wants to come to the United States, on all the things I can say is there is opportunity. You don't have to work in Walmart. You don't have to drive Uber. You don't have to, all the menial jobs that people come in here to do. You don't have to do that. You can actually get into this program, do the program. Being doctors and being people who are graduates from Nigeria believe they should be able to do that course and pass it. And then they would start applying and start gaining experience, even if it means shadowing. Shadowing is working like a volunteer. You don't have to be paid. You just want to get the experience. But once you get the experience, then the money starts coming in. And bet you are going to be paid more than somebody who goes out in the morning driving Uber, driving DoorDash, driving trucks and the rest of them, when the person is actually a medical doctor from Nigeria, or the person goes to the hospital working as a CNA. But you can stay in the comfort of your home, take care of your children, take care of your needs. You can even do homeschooling, and then you'll be able to still do your job and, take care. There is work-life balance with this very particular career. So I just want to encourage you, if you have somebody, a husband that needs to hear this, you can go to our YouTube and then, get the video, and both of you can listen to it. And if you have any question, I wouldn't like to share Yemi's contact online, but if you have any question, do come to Decency and Class Academy, and we'll be able to get Yemi privately to respond to your question. And on this note, I want to say a very big thank you to Yemi. Yemi, thank you so much. You are such a good presenter. You were just rattling the thing out like you were in the midst of 100,000 audience without even blinking. But thank you so much. That was awesome. We really appreciate you coming to the program today. And we do wish that we will call you. Like you said, this is not something you can teach in one day. I know it took you a process to get to where you are. And this is our own first step. We are getting there. We are trying to get our footing. And by the grace of God, by the time we are able to make that move, and we have any challenging again, we have people coming to us and say, please, can you bring her back again? Please, 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 when we beg you to come, please just oblige us and come to the program and also take more questions, okay? Do you have any final word for our audience today?
Well, I'll just say that I don't know, but I'll tell you that if you are in Nigeria and you're coming over here, I'm sure you're going to love it. And if you are here already and I'm sure it's going to work out. This is the land of opportunity. And as registered nurses, the sky is just the beginning. Like, you just reach for it and you get it. Just have the mind that you can do it and you will do it. You will do it.
Good,
it's just
good.
that thing that matters.
Good. Thank you so much, Yemi. This is coming from somebody who has been a Nigerian nurse, somebody who has been a UK registered nurse, and somebody who is currently a USRN. Not just that she's a USRN, she's a no-stopping lady. She's always going. She keep it going. From being a registered nurse in the US, she went into the OR. From the OR, she's currently in the Clinical Documentation Improvement Unit as a specialist in her own field. So thank you so much for coming to the program, and we wish you all the best in your master's degree. You know, we hope that when you get that feather added to your cap, we'll come here again and celebrate you, okay? Thank you so much, and God bless you for coming. And I want to thank our audience. I want to thank our audience. As is my routine, I always call you guys by name when we want to end the program. So I want to say very big thank you to Vivian. Thank you for your question. Thank you, Cynthia, Odo, Nancy, Samuel A. Is it Pelzy, and somebody with a Samsung phone, Helena, Ezekiel Joy, Azizat Oladepo, Angela Okunta. Thank you very much for coming. Thank you, Nancy. Is this my own Nancy? I have an instructor that is the Nancy. Thank you, Chinonye Rosemary. Thank you for your question. Thank you, Chekube Jenny. I'm celebrating you. Somebody passed her ankles, and her name is, I think, I missed her name right now, but is somebody that just started me up now. She passed her ankles. Congratulations, Jenny. Her name is Jenny. Thank you, Aloysius Idris. Thank you, Rashiti. And thank you, Galaxy 820. Thank you, everyone that is here today. It's such a pleasure to be with you guys, and look out for our program for next year. I wish you guys all the best of the season. I wish you a Merry Christmas. If we don't get to see ourselves, we'll see in the new year, and we'll continue working on this very project. Thank you, and God bless you. Bye, everyone.
Bye.